My name is Dr. Jeffrey Higgs, and I'm going to be demonstrating an ACL reconstruction using the ConMed femoral and tibial exoshapes. So just to orient, this is a right knee, and this is the ACL footprint on the tibia and the ACL footprint on the femoral condyle. For demonstration purposes here, I'm going to do a notchplasty. So I set my guide at 55 degrees. The angle of my tibial tunnel in the coronal plane is 65 degrees from horizontal, or 25 degrees off of vertical. As long as you go at the junction of the anterior third and the middle third of the MCL at 55 degrees, you're always going to get a tunnel that's long enough for this device. We've harvested a semi-T and a gracilis. We're going to size our graft, that's an 8. And then we go up 1 millimeter on both the tibial and the femoral tunnel. While protecting our MCL, we ream the tunnel. You can see that there's a thin wall left of our medial tibial eminence. We want to preserve this. When I drill my anterior medial portal, I want to be at 10 o'clock on the clock face. I get my assistant to flex the knee to about 110 degrees. When I ream the femoral tunnel, I want to get to about 30 millimeters if I can. Anywhere between 27 and 30 millimeters is long enough. This is the femoral exoshape device. It comes in this position, and once it's deployed in this position, you can see how it has shrunk down to 21 millimeters. What happens is these two wings here deploy into the tunnel wall, and then these block lock wings deploy against the soft tissue and compress the soft tissue against the wall, creating a radial force. So in this orientation, the block lock wings will deploy medial and lateral, but if the surgeon inserts it like this, these block lock wings are going to deploy anterior and posterior, and this posterior block lock is going to push against the back wall, and you do not want that to happen. That's too much force on your posterior wall. So I'm going to load the 2 hamstrings double over, creating 4 tendons going across the joint. And once they're evened out, I lock them on the handle. And I want to measure from the end of the device, not the end of the tendon, 25 millimeters. We want this device to deploy slightly deep to the cortical bone, so it's cancellous fixation, which creates aperture fixation at the entrance of the femoral tunnel. I want to compress the graft against the device. So I start with 1 millimeter up, so I drilled a 9 millimeter tunnel, so I start with a tensizer, and I just slide that easily over the graft. Then I go down to the size of the tunnel and compress the graft against the device so that when I insert this, it inserts relatively easily into the tunnel. Prior to placing my device, I'm going to pass a suture into the joint. I'm at 110 degrees, which is the same drilling angle. So the tendon on the left are going to create the posterior lateral, and this side is going to create the posterior medials. I will usually rotate about 30 degrees to recreate the normal footprint. And I want to bury the marking slightly and see how it inserts. So to deploy, what I do is I take this off, and on the back handle here, I unlock that, and I firmly press against the bone as I deploy. You can see it pulls the graft in a little bit, so there's an audible and palpable click that lets me know that my deployment is complete. And if I take the handle and do this, now there's no resistance. So at this point, I need to extract the insertion device from the implant. And the way to do that is to slide this forward like this, and then I twist counterclockwise like this, and I feel a firm resistance, and it takes multiple turns, and then I simply extract the device. You can see that I'm firmly implanted in the femoral tunnel. I want to create a triangle here, and that's just verification that I'm low enough on my wall to recreate the posterior lateral and the anterior medial bundles. And then I want to insert my graft into this loop. And I hold tension. I want to make sure that I get my passing suture in first, and then pull the graft into the tunnel. This is my tensioning device, and you want to wrap the tension sutures around the device and then slide them back into the outside slot one more time. And then I want to pre-tension my graft, and then I move the knee through a range of motion several times, and this will get rid of creep in the graft. by dilating the tibial fixation device, can compress the soft tissue against the bone. So the more you dilate, the greater strength of fixation you're going to have in your implant. And that tells me I'm a 30 millimeter, it's 30 plus 5 and then plus 10. I usually go to plus 5, and I simply mallet this in like this. And usually if you start 2 millimeter down, it should go in without a significant resistance. And now I've gone to an 8, and I'm tapping this in. I'm getting pretty good resistance, but there's still a little bit of play. So I think I'm going to go up one more. And again, go to plus 5. You can see with 2 fingers, and I try to twist it, I can't twist it. That tells me that I've dilated my tunnel to the point that I maximize the strength of my fixation. This device comes like this, and you can see that I've dilated to a 9, and they're color coded. So once I know I'm a 9, I go to the same color insertion device. This implant is designed to go so that this is the superior portion and this is the inferior portion. Because we're at an angle on the tibia, my anterior medial bundle, which will align here, and then my posterior lateral bundle will align here. This PEEK material has been manufactured in a round position, and then it's been deformed for packaging and then deployment. So this implant wants to be in a round position, and when this bullet slides into it, it'll spring into a circular position and compress the graft against the bone along the whole length of the implant. To insert this, you put the bullet inside here like this, and this comes at an angle like that. So I want to make sure my angle's lined up. We're going to achieve aperture fixation on the tibial side as well. And I rotate about 30 degrees to get the position I want. And then I also mallet this into place. So I've inserted my implant so that the most distal portion, or the portion closest to me, is slightly deep to the cortex. I remove the insertion device, and my implant is still in place, and I move the bullet towards the implant like this. And then I load it on this gun. This clamp closes down like this, and when I cock my gun and squeeze the trigger, and the implant will spring into a circumferential round position and compress the soft tissue against the bone. And then once I can't squeeze anymore, and I hear that audible and palpable clunk, I know that I'm inserted. And then I twist to remove this portion of the insertion device, and that's what the implant looks like deployed in the tunnel. What I will do at this point is cut my graft and my sutures. And then once the implant is deployed in the tunnel, this is what it looks like. So now that we've completed our procedure, you can see we have a nice horizontal graft. We have a nice triangle between the PCL, the roof of the notch, and the ACL here. This is our anterior medial bundle coming down here, and our posterior lateral bundle coming down behind in the posterior aspect of the tibial tunnel. And this is our implant right here. So you can see we have aperture fixation here on the tibial side, and then we have aperture fixation on the femoral side. A nice tight graft.